So good afternoon. Thank you for coming to our session on EPAs. We know that you had a choice about which sessions to attend right now, and anybody who interacts with trainees is going to be using EPAs, so we think that this session is really important. We're going to start with brief introductions of ourselves, and then we'll hop right in. My name is Samantha Alley. I'm a pediatric surgeon at Hasbro Children's Hospital in Providence, Rhode Island.
Hi, Stephen Lee. Oh, sorry. Stephen Lee doesn't know how to use a microphone. Seattle Children's.
Raquel Gonzalez at Johns Hopkins All Children's Hospital in St. Petersburg, Florida.
I'm Mina Wick from UC Davis in Sacramento, California.
And Pramod Puliganla from Montreal Children's Hospital.
Great. So by a show of hands, how many of you have heard of entrustable professional activities, or EPAs? Okay, pretty good. How many of you have used them so far? Okay, fewer of you. So we hope that by the end of our talk, you'll be able to define an EPA. You'll be able to describe the general surgery EPA requirements set forth by the ABS and how they are to be implemented. And you'll be able to utilize the EPA framework to provide formative feedback to trainees. And with that, I'm going to turn it over to Dr. Lee.
Great, thanks and welcome everybody. So we'll start with the why. Why do we have a problem? Why are we discussing EPAs? And the ideal way to determine a trainee's ability to safely function independently at the completion of their training is still in question. Despite a lot of work and focus on developing core competencies and competency-based evaluation tools, there still remains many issues, including transparency for increasing autonomy of our trainees. Competency framework has been artificial and abstract. There's dissatisfaction with the current assessment systems. And frankly, it's not a one-size-fits-all. We produce a very heterogeneous product. Next slide, please. Here are some articles, and even a New York Times article questioning the quality of our product, which from the board standpoint really hits us to the heart. And we really have the responsibility from the American Board of Surgery to ensure to our public the quality, the consistency, and the skills of our certifying diplomats. So when we look at evaluating our trainees based on the core competencies, and that's where things have headed over the last 20 years, is really focusing on the 6 core competencies, it's not so straightforward. I think when we work on a day-to-day basis, we can evaluate our trainees pretty easily on medical knowledge and patient care. Not so easy when we think about interpersonal communication skills and professionalism. And for me, I still really struggle with systems-based practice and practice-based learning. So, these competency-based evaluations are fairly abstract and theoretical, and they're not really integrated in our daily work. So EPAs are a more concrete and practical way for faculty to integrate their assessments on a day-to-day basis. For these reasons, the American Board of Surgery has adapted trustable professional activities as a solution. So before going into depth about what specifically is an EPA, tips on how to implement them, and how they will be implemented in a pediatric surgery training, I want to give you a brief overview. EPAs are defined as a discrete element of surgical care that assessors can relate to and more objectively evaluate. And more importantly, EPAs actually start with the end in mind. It really carves out what we want our graduates to look like, what our trainees are able to do at the completion of their fellowship or residency. And then we are able to develop independent assessment tools. So with that, I'm going to turn it over to Dr. Ali for really giving you more nuts and bolts on what an EPA is.
So all this talk about why we're embarking on this journey, but what exactly is an entrustable professional activity, or an EPA? An EPA is an individual unit of work that can be observed and evaluated. Just like an RVU is meant to describe or represent a clinical unit of work, an EPA is meant to represent a unit of work for knowledge, skills, behaviors, and attitudes. They are meant to be directly observed as part of regular clinical workflow. They're meant to be task relevant using knowledge, skills, and attitudes and behaviors. And it's an opportunity for an evaluator in a real world situation to take a snapshot of ability. This is compared to the inference that we sometimes use now from PD attestations, from test results, from case logs. They're meant to create a shared mental model across all evaluators, across institutions nationally. They collect micro-assessments that automatically capture key information, and this can later be fed into competency-based education, such as the milestones. And in conglomerate, they're supposed to define the scope of a specialty. This figure is representative of how the American Board of Surgery defines general surgery and the EPAs that make it up. Importantly, this year, vascular surgery EPAs are going to be launched, and next year, in 2025, EPAs are going to be launched for surgical critical care, surgical oncology, and even more relevant to us is pediatric surgery. So an important part or factor of EPAs is that they're meant to inform our competency-based structure. So how do EPAs differ from competency-based education? The EPAs themselves are the unit of work a physician performs that can be directly observed. It's things that we do, such as evaluating and managing a patient in a workup like acute appendicitis. Competencies are broad and foundational domains of ability, such as medical knowledge or interpersonal skills. And the milestones are the capabilities that describe progress that advance the level of competence, and it ranges from novice all the way to expert. I find this figure helpful in further understanding the definitions. So in EPA, the unit of measurement is the activity itself, whereas in the competency, it's the individual. An EPA is a formative microassessment, whereas a competency is meant to be a summative assessment. An EPA is embedded in clinical context, whereas a competency is context independent and ranges across all competencies, or EPAs. A competency addresses the knowledge, skills, and attitudes of a specific ability, whereas an EPA combines them and measures multiple competencies to address a behavior in a more realistic, integrated fashion. And an EPA has a floor of competence, whereas competencies do not have a minimum competent performance. I find this figure even more helpful to view their relationship, and I'm going to start in the right with the milestones. So the milestone itself is a specific, observable, and measurable step that residents achieve as they progress in their training. It's a marker of a resident's development, and it's used to provide feedback and guide further learning. Moving to the left, a competency represents broad areas of skills, knowledge, and attributes that surgical trainees need to develop by the end of their training, or the overarching goal of a training program. The ACGME has defined these as medical knowledge, patient care, interpersonal and communication skills, professionalism, practice-based learning and improvement, and systems-based practice. The EPA is the entrusted task or responsibility that a trainee performs, and it translates the competencies into clinical practice. So it's a bridge between the conceptual competency and the practical clinical task. And each EPA encompasses multiple competencies. So in summary, the EPA is the real-world task that allows application and assessment of the competencies. The competency is what a resident needs to learn, and the milestone marks the resident's progress toward achieving these competencies through successful completion of the EPAs, ensuring that our surgical training is comprehensive, allowing residents to develop the full spectrum of skills necessary for independent practice. And with that, I'm going to turn it over to Dr. Gonzalez.
So let's look at the EPAs from a practical standpoint. And we're going to look at it looking at the general surgery EPAs that already exist. But in order to understand this, we have to understand the framework that was used to define the entrustment level, which is that level of supervision needed to get our trainees to autonomy. Here, level 1 is limited participation. In essence, it's an attending show and tell. Level 2 is direct supervision, where the attending is giving the steps to move the operation forward, and the learner knows the tools but just doesn't know how and when to use them. Level 3 is indirect supervision, where the learner can perform straightforward operations and the attending scrubs for the more complex cases. And level 4 is practice ready, where the learner has strong understanding of surgical options and techniques for less common scenarios, so the attending is pretty much available upon request, especially for consultation of complex cases. So in essence, the level of entrustability for the same EPA is going to vary based on the complexity of the patient, the difficulty of interpersonal skills. So you can have a trainee that you're going to evaluate, but your EPA might be a little different. Next slide, please. When we look at a specific EPA for general surgery, and we're going to use the right lower quadrant pain and appendicitis, limited participation uses the framework what a learner directly out of medical school should know. So preoperatively demonstrates understanding of basic pathophysiology of the appendix and right lower quadrant and can apply this knowledge to other causes of right lower quadrant pain. The learner can communicate the elements of an informed consent, but when document perhaps forgets some of the elements. Intraoperatively can demonstrate understanding of the principles of maneuvering and focusing the scope, but requires adjustments to center the operative field. Requires active instruction to move the operation forward. Postoperatively can recognize complications, but needs to alert someone to initiate the management. Or can communicate basic aspects of the operative procedure to a patient or caregiver, but will need some prompting to clarify the expected outcomes or an anticipated treatment course. On the other hand, a practice-ready trainee has the skills to treat all straightforward appendicitis patients and has a strong understanding of surgical options and techniques for less common scenarios. So preoperatively can manage a patient with a complex medical history, such as a pregnant patient or somebody with inflammatory bowel disease, or how to manage a patient who's on anticoagulation that needs reversal. Can conduct an informed consent for a complex or emergent appendectomy with cultural humility, can elicit the patient's preferences. In the OR, can access the abdomen safely in a patient with prior surgeries or a pregnant patient, can analyze how the choice of the instrumentation will affect the overall cost of the procedure. Postoperatively, can manage conflicts between a patient, a caregiver, and the healthcare team, and then knows how to select a method of postoperative follow-up considering case complexity, the healthcare system cost, and the patient's wishes and resources. So you can have one EPA is going to cover several competencies, and one competency can be covered by several EPAs. Can I use EPAs for feedback? Well, in itself, it's not a tool for feedback, because like we said, it's a framework for activities and tasks that the trainee can do to accomplish, to demonstrate that they're independent. But you sure can use this as a tool to provide feedback. So for example, if I fill out an EPA and I identify where the learner was at and where the learner was expected to be, then I can highlight that knowledge gap and the trainee can then work on improving and getting to that next level. So in essence, they provide the opportunity for frequent, time-efficient, feedback-oriented, and workplace-based assessment in the course of daily clinical workflow. They offer the opportunity to operationalize competency evaluation and related entrustment decisions in the regular patient care. They help bridge this beast of core competency theory with the clinical practice. They capitalize on the in-moment decisions that you as attendings are already making as to whether or not the trainee is autonomous or not, and they inform trainees' progress towards entrustment.
Next, I want to talk a little bit about what you might call tips and tricks. But really, it's about how do we change the culture to a competency-based education. It's easy to look at EPAs and think, this is just one more thing I have to do when I'm trying to talk to the patient and dictate my op note. How am I going to find time to do this? It's just another burden that I have to address. But really, this is a representation, it's a tool that we can use to try and advance our medical education. And so I want to talk about tips and tricks in the context of Kotter's conceptual model for driving organizational change. Some of you may be familiar with this 8-step model from business or leadership standpoints, but I'm going to apply it today to the EPAs. So the first step is to establish a sense of urgency. For the EPAs, we found it helpful to frame the EPAs in the context of what our institution needed. So before we launched our EPA initiation, we actually sent a survey to all of our trainees and to our attendings to ask them, what do you like or dislike about feedback and evaluations at your training program? It was a constant low point on our evaluations. We found from our residents that they wanted feedback that was actually constructive, that was specific, that was more frequent. And the attendings wanted the residents to participate in this conversation. They felt like the residents didn't really care. And they also wanted to be able to give honest feedback without worrying about the repercussions of being labeled harsh or being accused of mistreatment. So in that context, it was really easy to tell our residents and faculty, hey, we have a problem, but the EPAs are something that can potentially help us address all those needs. The second step is to form a powerful guiding coalition. So another tip is to recruit champions, ideally both a faculty and a resident. When we were first introducing the idea of EPAs, it was really helpful to have senior surgeons stand up at grand rounds and say, I have used it. It works great. It takes me less than 30 seconds, and it's really helped my relationship with my fellow, and it's really helped me be able to teach in a quick and specific manner. We had residents who stood up and said, so-and-so told me I was autonomous for this. The next time the attending let me do it by myself, I learned a lot, and it really helped me take that step forward. And they've been really vocal champions to help convince other people that this is something that's at least worth trying. So recruit champions. The next step or trick is to create a vision. What's the goal and why? Is it really just to meet these graduation standards that are laid down by the ABS, or do we really want to create a culture where feedback is encouraged, expected, and done in a respectful and reliable manner? That was our goal. That was our vision. The next tip is to communicate that vision often and in multiple formats again and again. So we did grand rounds, we did faculty meetings, we did division talks, we've been doing small groups with the residents. And every time you communicate, it's going to be a little bit different depending on what it is you want to communicate in the audience. So for residents, these are the essentials that we highlight. The EPAs can be resident or faculty initiated. And it's really important that the residents know that if they want to view their completed evaluation from a faculty, they have to do their own self-assessment. So that helped to address resident and faculty's concern that residents weren't participating in this. Now the faculty know that the resident also has to participate if they want to get anything out of it. It's also important to emphasize that the feedback addresses all phases of peri-op care, not just intraoperative. I think that's when it's most natural for us as surgeons to give feedback, but the EPAs also include preoperative and postoperative care. We also told them about the due dates and the requirements. So for our currently starting class, this is a graduation requirement. But we also told them when you're on this rotation, these are the EPAs that you can expect to be collecting. And we also gave them a target of collecting 2 a week. We taught them a lot of times about how to use the mobile app. There are a lot of resources from the ABS on how to do this. And then we really wanted to emphasize the why. Why are we asking you to do this? Ultimately, the residents want to become safe, independent, and competent surgeons, and they want to do it as fast as possible. And then they get to chief year and they're like, oh my goodness, am I really ready for this? And so we kept reminding them that the EPAs are to help them learn better, faster, and stronger, just because it fits better in the motto that way. These are some of the details about how residents can use EPAs to take charge of their surgical training. It gives them an opportunity to participate in that self-assessment and to obtain feedback. It also helps them start that conversation without being awkward about it. And so they could just come to their attending and say, do you mind filling out an EPA for this? Or if they fill out that self-assessment first, it shows up in their faculty's inbox. And then the EPAs can also help the residents pinpoint their own areas of relative strength and weakness. One of the things that some of our faculty consistently noticed was that residents often graded themselves harder than the faculty did. And so once they started participating in this, the residents actually started to gain more confidence about what faculty recognized that they were doing well. The EPAs, like Dr. Gonzalez already showed, also provide a roadmap. And so they have really specific goals that they are shooting for. Because remember, for feedback, good feedback is not just about the gap or what the resident is doing wrong. It's about what that goal is and providing feedback about how they can get to that goal. And so the EPAs provide a whole roadmap of little goals for the residents to achieve. It also forces the resident to take ownership and to trigger the request for an assessment. And it also gives them data when they want to ask for more autonomy. They can say, last time I did it with so-and-so, they rated me at this level, so can I, this time be prepared to do this step and this step? I'm not just asking, I'm actually prepared to do it. For the faculty, again, we wanted to emphasize that EPAs are both resident and faculty initiated. And then we were very specific about which EPAs they're responsible for. To tell one single faculty member that they have to know all 18 EPAs just wasn't realistic. And so we picked a couple faculty members who are responsible for the thyroid one division that's responsible for trauma. There's 2 surgeons who are responsible for the breast one. There's 6 of us who do the API one, and that makes it much more manageable for the faculty to do. We also reminded them it only takes less than 2 minutes per EPA. Not a lot of time. We also showed them multiple times how to use the mobile app. And again, to emphasize the why, it's not to provide more burdens. I think a lot of, if not all faculty who are at academic institutions, who are at teaching institutions, they take great pride in their role as teachers and see it as a huge responsibility and a privilege to teach. And so this is a tool to help you teach better and faster. For the faculty, we emphasize that it provided a shared language and a way to give constructive feedback without taking on all that emotion that may be tied up in it. So you could give constructive feedback that was based in EPAs without worrying about being seen as too harsh. The next tip is to empower others to act on the vision. So we frequently circled back to ask, what barriers are you encountering? How can we help you? If people had ideas about how to make it better, then we were willing to try it. Right now we have a resident, his idea is to see if we can implement a nudge into our EPIC system after an operation to say, hey, remember to go fill out an EPA. And so we empowered him to act on his vision of how to make this better. Step 6 is to plan and create short-term wins. So rather than just waiting for 2028 to say, yay, we got all of our graduates to EPA competency, what are some short-term wins that you can celebrate and establish? And what are some positive experiences that you can highlight publicly? Step 7 is to consolidate improvements and produce still more change. So we provide feedback to different faculty and to different divisions about their completion rates, highlight good and bad examples at faculty meetings about some of the qualitative comments that are made, and we also focus on then setting higher goals once divisions have met those short-term wins. And the last is to remember that the goal is progressive engagement. This is going to take time. No culture change happens overnight. And I think speaking with other people who have been EPA champions, sometimes these get off to a hot start and then it kind of fizzles out. And so it takes a lot of momentum to maintain, but that's where all the other tips, like having frequent communication and having champions, really helps.
Thanks. So what does this mean for pediatric surgery? Together with my partner in crime, Dr. Lee, we've been leading an effort through the Pediatric Surgery Board, and this is a diagrammatic representation of the EPA suite. So we have 19 EPAs with the optional obesity EPA, which really covers what we believe are the essentials or what defines us as a specialty. Next slide. So I just wanted to highlight what the process is. I think Dr. Wick did a wonderful job of the tips and tricks, and there's a lot of work and a lot of effort that's gone to get to this level. First, we had to create a scope committee, scope council that defined the breadth of the specialty, and then the writing group, which again, both groups were geographically, practice type, and EDI informed in terms of the contributors. And then they had to describe what we were actually trying to do with those EPAs, and that was provide descriptions and learner functions. These then had to be vetted by the scope council to ensure that what they had envisioned was actually being done by the writing committee. And then we went ahead and started preparing the milestones. This included the mapping of the EPAs to the milestones, developing a cognitive framework, and then writing the expected behaviors. The two elements that are in red is where we are right now in the process. We are doing the behavior harmonization to ensure that all of the behaviors are similar across the different milestones and across the different levels. And then there's going to be several elements of verification along the way. Next slide, please. So this is just a diagrammatic representation of what the EPA implementation timeline is. So if you start at the left side, April, May, we were hoping to be able to socialize the EPA suite to the program directors. We will probably be done the behavior harmonization within the next few weeks. And Steve and I did present to the program directors earlier in the meeting to tell them this is going on. What also has to happen are several levels of verification. One, there's a medical writer who will make sure that the verbiage is correct. There's also vetting by the Scope Council, the Pediatric Surgery Board, EDI Committee, as well as the Assessment Committee at the American Board of Surgery. What we're hoping for is that once we hit September, we will actually be able to launch a pilot. And this pilot would include 15 or so programs so that we would then be able to allow a soft launch. Try to understand where things work well, where things don't work well, in order to create a suite of best practices, which we then hope will be able to benefit all programs, all pediatric surgery training programs. We're hoping that this information, by the fall, we will be able to reinforce this at the American College or the AAP meeting, and also try and get these best practices on the American Board of Surgery site. Ultimately, once we get into 2025, that's when the pressure is going to be on and where we're really looking to try to iron out the implementation process. What we hope to do at that point will be to get these best practices out for everybody, to ensure that the whatever information technology system, because Simple is not the only product that is being used across the country, but that all of that is working appropriately, and that we will then be ready for our launch in August 2025. I think Dr. Wick did a phenomenal job of going through all the tips and tricks, and I think it really does require some reinforcement with respect to how you can go ahead. You really do need champions within your division, and those need to be identified early. And in fact, your residents and trainees can be those champions. A program coordinator, they're going to be at the fulcrum of between the program director and the trainees, and they need to be informed as well. And it's really, really important with respect to how you're going to be able to socialize the EPAs within your group. Part of this might be mapping, so within your divisions you may have specific individuals for whom a specific set of EPAs would be most pertinent. They may not need to know all 19, maybe they only need to know 4, and I think that's going to help with your ability to engage them in that assessment process. One of the other things that is really important is to understand that you can also engage other non-surgical individuals as part of your champions. So you can talk with other health professionals in order to help you with that. Next slide. I think one of the other things is about scalability. You may be able to start really fast. Some programs may start a bit slower, but what you want to be able to do is progressively increase the engagement of the faculty. And part of this might also be with respect to how you can keep that faculty engagement. To reflect on the Canadian experience, since we've been doing this now since 2020 in pediatric surgery, is that there is this element of evaluation fatigue. We started with 45 EPAs, and that was way too many. And so our specialty committee has now decided that we're going to cut that in half. I think hitting the 20 EPAs of what we have right now is probably the sweet spot. But again, this is going to require ongoing evaluation. Within the first couple of years, we're probably going to go back and say, okay, what worked, what didn't work, and perhaps there's something new that comes up where we have to have another EPA developed and another one gets jettisoned. And with respect to sustainability, it really has to do with maintaining the fact that this is what our trainees want, this is what we do every single day, and to try to operationalize it and to use best practices. Personally, I tried to do something called an EPA timeout at the beginning of a clinic or at the beginning of an OR list. So I say to my trainee, okay, we have a bunch of EPAs or a bunch of patients, let's take one EPA, it's going to be a baby inguinal hernia, let's go and let's see what's going to happen. So then you actually have already a priori initiated that and then be able to engage. And it really does only take a couple of minutes to be able to fill it out and to provide that really authentic feedback. Thank you.
We wanted to leave plenty of time for questions and discussion, so I believe we have about 15 minutes left to answer any questions, thoughts, concerns you have about EPAs. You guys are all ready to use them.
Bo Lover in Nashville. It's been my honor to work on the writing committee for the EPAs. I've certainly learned a lot in that process. If I put on my program director's hat, how am I going to receive this information? In what sort of summated form will it be? And then how do I use it, present it to the graduating resident? Does it have to be reported to the board? So what's going to be my role as PD in how we use these data? Thank you.
I think a critical element of this is going to be your clinical competency committee. So what they should be able to do is to distill all of those micro assessments into something that is going to be tangible to address the progress of your trainee. And I think together with the board, we realize that we're probably not going to be able to hit number 4 in every single EPA. And that decision is going to have to be made as to what qualifies as adequate for practice. Is probably still a work in progress, and that will certainly come down from the board. And what we're hoping for is, and certainly in Canada, that's what we've done, that the Clinical Competency Committee has discretion and can make these judgments based on, again, thousands of assessments to say, you know, I think that this trainee has actually progressed very well, or based on these assessments, we don't believe that the trainee has actually attained that level of competence. I don't know if anyone else has any other comments to make.
Thank you for this, Ron Herschel and Arbor. This is a tremendous amount of work, not just developing, implementing, so on and so forth. So congratulations on that, and thank you for it. I was wondering about intraoperative assessment and how that fits into the EPAs, and is that is simple the mode that gets used to fit into the EPA and provide feedback, or evaluation and then feedback for intraoperative assessment? Just wonder if you could talk to that.
Simple is what most programs, from a general surgery standpoint, is what most programs are using. There's a handful that are using in-house developed apps, or Firefly, which was developed by a thoracic surgeon at OHSU. I think there's 6 programs using that one. I don't know what PEDS, EPAs are going to be using.
Right now it's simple, but programs are able to use what they would normally use. If their general surgery program is already using one platform, there's no point in having 2 platforms. So you try to use the same platform. But simple is what the board has established.
So the actual tool would be this. Right now, most places are using the simple app, but specifically to intraoperative or any other points of the EPA, if you're looking at tracheoesophageal fistula, esophageal atresia repair, there are clear steps of what's being written to address, so you can know exactly where they are. Like, they may be able to dissect out the distal fistula, but they're not able to really control it, divide it, and ligate it. Those are different steps, different levels that you'll move through. So it actually makes that abstract, oh yeah, I think there are 3 or 4 to really specific targets that they'll be able to accomplish in order to get that. But not only for technical skills, intraoperative skills, but interpersonal communication skills. How did they do to informed consent, as Dr. Wick mentioned, and API and all of those other things. So it's very specific and guided, and makes it useful in real-time clinical situations every day.
It's meant to provide behavioral anchors so that everything can be standardized across institutions. So what you might think is practice ready and someone else might think is really a level 3, we're trying to take that out of the equation and make it more clear for everybody.
So coming from a huge place where surgery is being done all over the city you're in, this is going to roll out in your minds through the program directors and the CCC. So are you going to make it super clear to them that you're going to tell the 16 people in your group how to do this, which EPAs each of them are doing? I recommend like real clear guidance to those PDs. Otherwise, this is going to take a long time to roll out. But if it's their job to do it, and all the PDs in the room, I apologize, but it is their job to get the groups to be clear and organized about it, it seems like it'll go a lot better. Otherwise, I'm going to have to call you and ask you what I'm supposed to be doing.
Yeah, that's a role of the PDs, but and as well as division leads and any of the leaders, as Dr. Wick mentioned, as far as getting champions. The key is there's going to be ongoing training, ongoing communication, multiple things coming out to make sure we communicate what's going on, how to implement this. I think Dr. Epperman brought this up at the board meetings, like, this is like, whoa, what is this? And then now so there's a lot of things that are coming out. There'll be train the trainers. American Board of Surgery has presentations that we can give at grand rounds. We can give presentations as well to different faculties, groups. So there'll be information videos. There's going to be a lot more communication about this moving forward. As for the program directors, we just brought it up a couple days ago, but again, we're going to have another meeting. We're going to let them review it, have a period of feedback, and answer more questions and details with the program directors. But there's a lot more to come, and this is really the first time we're wanting to introduce this concept to pediatric surgery, and more to come. I don't know if Dr. Puliganla has more to add.
Yeah, I think Steve covered a lot of the stuff. I think there's also opportunities for train-the-trainer, where, and you may have seen this on Twitter, where a specific assessment is actually going to be highlighted, and you would then participate in that assessment together with someone, so that you would sort of understand how you would go through the steps of actually being able to provide that assessment.
Andreas Meyer, I give you the not-so-happy story from a suffering general surgery program director. So we have been using Simple, which some of the pediatric surgery programs I think use as well, not the EPAs, but the original Simple that's only doing intraoperative evaluations since 2014. We were on the EPA pilot study since 2018. It is a struggle, and it may be easier if we have 45 residents. You have 2 to 3 fellows. I think that might be a little bit easier to roll out in most programs. It is a struggle. It is a struggle to get the residents involved, even though I loved what you said. I saw what you said, what the residents were complaining about, what the faculty is complaining about. We get exactly the same thing. We had multiple sessions about this is how you do it. We had Simple training before, so they were actually used what to use on the platform. It is a struggle. I really love your 8 steps. I think we have to implement that. I really love the fact that you kind of split it up. Certain people have to do certain EPAs. I think the one thing that you may have mentioned, I think finding a resident lead is a good one, because that is something we probably didn't do very well. We have some that are just doing it all the time, and we have some faculty that has over 1,000 evaluations, but we have others that have not done one, and we have residents that have not done one. Now, as far as the linkage goes for the program director, right now we're in a little bit of limbo, because Simple is switching over from the old app to the new app. So the new Simple that we used over many, many years is going to be integrated into the EPA app, but right now it's kind of in limbo. They're also planning on coming up with a much nicer dashboard for the CCCs, where you basically automatically link all the EPAs to the competencies that are in the milestones. So you get actually a report, and you can actually over time see how the competencies develop for the individual trainees. So that's pretty cool, but it's not, the University of Wisconsin has actually a very nice model. They're using a different system. They're using Firefly, if I'm not mistaken, and they showed it at a great announce in Syracuse. Really, really cool, because you see the progress of all the trainees in general surgery. So I think it's a good thing, but yeah, it can be a real struggle.
I think I don't think that's unique to your program by any means. When I was recently speaking with some colleagues from OHSU, they have gamified it. And so they have a leaderboard for both the residents and the attendings of who completed the most. And I had this surreal experience when I was having dinner with some of them, and one of them pulled out their phone and said, shoot, somebody overtook me in first place. I have to fill out 3 more right now. So I think that appeals to some people who are more competitive, which is many surgeons, but that is one strategy that some other people have used.
And more on the app, it's clearly not capable of keeping up with what we need. And when we were instructed to write the EPAs, we are writing it not based on the current technology as it exists today, but what we're hoping it will exist. So we don't want to write a set of EPAs now and then have to change it later on. It's going to be very clunky to start with until the technology catches up, which it should.
And then as a last comment, further to the rewards and sort of the gaming aspect of things, most of us are in academic institutions, and this is actually a portion of our responsibility. And so completion rates, stale EPA rates, Those are all feedback mechanisms for division chiefs and program directors back to faculty. So there is the carrot part. There can be also a little stick part to it as well with respect to getting faculty more engaged. And trainees need to also understand that they need to complete their EPAs in order to progress through. So if they don't fill them out, then they're going to be in trouble.
Hey, Steve, this is Jeff. I'm speaking on behalf of Jeff, and I'm not speaking as a board member in this moment. The question I have, though, is with regard to our external stakeholders. And have you, not as a board member, but as you, have you thought about how the EPAs as a construct may be viewed from a risk lens? You know, all of us have participated in RCAs. Do we imagine, you know, where we're pulling out this and, you know, this resident they were signed off of and they should have known or they did know, et cetera, because as I understand it, at its inception, some of this was really about, you know, residents off doing some independent things on the floor, not necessarily appendectomies, but other things that may have fallen into the EPA bucket, and they're unsupervised. And this was part of the dialogue that, you know, we've done all those things and we've signed off them so they are competent, et cetera, to do these. So how does this play out from a risk lens in your mind?
That's a great question and very thought-provoking, and one that I haven't really thought about too much, so I can't really give you a great answer from a risk standpoint. So I invite anyone else here. I would say that from a overall conceptual standpoint, it's really moving towards a time-based competency training program to a skill-based entrustment level program. So it could work the other way where somebody can actually accomplish what they need to do and be, you know, one of those that move forward faster than the actual time of the training required. So for us, for fellowships, 2 years. Somebody may be ready in 18 months or 21 months earlier, and some may actually need more time to complete and be ready for practice. So from that standpoint is one of the intentions of of using and developing these tools. So, but I would leave it to anyone else to answer that question.
Yeah, I think, you know, the current system is that it's basically a signature from the program director, right? And you get your quarterly ITER filled out and people kind of make comments and such. But here, you're hopefully going to be able to support that promotion aspect because you will have hundreds, if not thousands, of micro-assessments that are going to support that for whatever direction you're going to go. I do believe that there probably are issues, and in Canada we've had that too, as to what do you do with the individual who, in your non-time but your time-based training, has not yet met that bar. And the question, and I guess you could use the same question as to, you know, case volumes. That if a fellow has not reached their case volumes, it's the same argument. Like, how are you going to be able to try to mitigate that? So I also believe that the EPAs provide us with an opportunity for earlier identification of trainees who are having problems. And I think that, and that's where the CCC is so important, that if they're able to distill this down and we see that there's a plateau in progress, and there could be many elements as to why that trainee is not progressing, but you can pick them up hopefully very quickly. And that dashboard is where the program directors can, you know, on a monthly basis can sort of see, well, what's my trainee doing and how are they, you know, what's happening, and you'll be able to follow that and intervene hopefully expeditiously to be able and mitigate any problems that might be there.
Thank you.
I think we have time for one last comment or question.
Yeah, it's actually just a comment. The data are owned by the American Board of Surgery, and it's going to be the same, I think, for pediatric surgery. So I don't think they're necessarily accessible to anybody else. And Simple, who actually organized the data collection, is a health protected agency, so the data are not, will never be released to anybody.
All right, thank you all for coming to attend our session. We have a 15-minute transition time to find your chosen first break shop session for the day. As a reminder, the break shops are listed in the app, and there are electronic signs outside each of the room with the name of the session. In here will be the vascular access in neonates and infant session, followed by the DEI session on pathway programs after a break.